Myself, I am Julie Swaney and at University of Colorado Hospital and will be moderating our session today. This is Ethics Grand Rounds from University of Colorado Anschutz Medical Campus. Very, very honored to introduce our speaker for today on current ethical controversies in organ donation. Our speaker today is Dr. Brian Jackson. Dr. Jackson is an associate professor in pediatrics and pediatric critical care medicine at our Children's Hospital Colorado here on our campus. He is the medical director for clinical ethics at Children's Hospital Colorado as well. And he is going to speak with us again on ethical controversies in organ donation and where we are with that. We'll ask all of you to put your questions and your comments in the chat, and we will read those to Dr. Jackson to engage in conversation around those. And I will introduce or mention, by the way, that our next Ethics Grand Rounds session will be in January 11th, and that will be on conscientious objection by Dr. Matt Winia. So that will be in another month. But for today, want to turn this over to Dr. Jackson, and we'll hear what he has to tell us about ethical controversies in organ donation. Thank you, Dr. Jackson.
Thanks, Julie. I appreciate your having me just share slides here. And is that sharing okay?
Yes.
Perfect. Great. So again, thank you for having me. I will be talking about organ donation and controversies that exist there. I don't have financial disclosures. I am the co-chair of the Donation Council at Children's Hospital Colorado and serve on the Donor Alliance Advisory Board, which is the organ procurement organization for Colorado and most of Wyoming. Both of those are unpaid positions, and nothing off-label will be discussed today. So I'm going to start before I get into the actual controversies by reviewing some of the organ donation process. For people who work outside of an ICU setting, the organ donation process is often a little bit of a mystery and frequently misunderstood. So I think before we can understand why there might be controversy in some of the techniques and practices that exist, we need to understand what we're talking about and make sure that we have that shared understanding. So just to be clear, when I'm talking today, I'm talking about deceased donor transplantation. Many of you may be aware that there is also such a thing as living donor transplantation, which is when a non-vital organ, such as one of two kidneys or a portion of the liver, is removed from a person who remains alive and then transported into a second person who is in need of that organ. That's not what I'm talking about today. There are a whole host of ethical issues that may be related to that. But what I'm really focused on today is deceased donor organ donation. And deceased donor organ donation is governed by the dead donor rule. The dead donor rule, put simply, requires that patients be declared dead before the removal of any life-sustaining organs for transplantation. The reason for this is that if you remove a life-sustaining organ from a person who is still alive, you killed that person. And in most places in the US, that would be considered murder, manslaughter, and illegal. We don't want people, our surgeons, our transplant surgeons, to be doing that. And so we've created this rule that says that a person must be declared dead prior to removing a life-sustaining organ. So that would include the heart, the lungs, the entire liver, or both kidneys. All of those are considered life-sustaining organs. When we talk about deceased donor donation, there's two paths that we use to procure organs using deceased donors. The first is called donation after neurologic death or brain death. You'll hear me refer to it both ways. The literature generally prefers the term donation after neurologic death now, but brain death is still commonly used in a lot of clinical settings, so I'll use both. The other technique is called donation after circulatory death, or DCD. In the next couple slides, we'll walk you through what happens in each of those processes. So for brain death donation, or donation after neurologic death, the first thing that occurs is that the patient, the donor, has a devastating neurologic injury. That injury can be caused by a variety of things. It could be a cardiac arrest or a traumatic injury or a bleed within the brain caused by a medical condition. Anything that causes a devastating neurologic injury could potentially qualify. At some point, The team that is caring for that patient in an intensive care unit will decide the patient would meet the criteria for brain death. Just as a side note, in the last couple months, we've had new criteria for brain death published as national guidelines. So those guidelines have changed a little bit, but our ICU teams are very familiar with what brain death testing involves. That brain death testing indicates that the entire brain has ceased function. So all of the brain, including the brainstem, is no longer working and has no chance of recovery. Brain death testing is a form of legal death, and so that's why donation can occur. The way organ donation fits into this process is that the family is approached either prior to brain death testing or after brain death testing, or in the case of pediatrics, where brain death testing occurs over a longer period of time, potentially in the middle of multiple sequential exams for brain death, just because of the way the process for pediatrics works. But in any event, the family is approached by a representative of the organ procurement organization to see if they would be have their relative interested in donating their organs if they were to be declared dead. At the same time, the organ procurement organization would review the donor registry in the state where that OPO is working to see if the patient themselves had agreed to be an organ donor prior to their injury, prior to their neurologic injury. So that's the box that you might have checked on your driver's license when you go to the DMV to get one. There are a few other ways you can get on that registry as well. Using that registry is referred to as first-person consent and is another way that organ procurement organizations can get authorization to procure organs from people who are deceased. So when I say family approach, that includes both the family being approached as well as review of that registry. If the family does not agree to donation and the patient is not on the organ donor registry, we'd follow that no consent arrow going up. The physiologic support of the patient would be withdrawn in the ICU. So that means the ventilator would be stopped, blood pressure medications, IV fluids, all of the support that we as intensivists provide patients to keep them alive or to support their organs would be stopped. The patient's heart would then stop, and we'd provide grief measures for the family. If, however, the family did agree to donation, or if the patient was a first person authorized donor, we'd follow that lower arrow where it says consent given. At that point, the patient would be maintained on physiologic support for their organs. So the ventilator would be continued, blood pressure medications, endocrinologic support, whatever support that patient needs in order to keep their organs healthy would be continued. The patient would then be taken to an operating room where an organ procurement team would recover whatever organs are to be transplanted into another person. The physiologic support for that patient is then withdrawn in the operating room, and grief measures are again provided for the family. You'll notice on this slide, I also have an orange line, and I think this is an important line to keep in mind as we go throughout this talk. That orange line distinguishes care that's being provided by an ICU team that is really focused on the good of the patient or trying to keep the patient in the best condition possible. The area below that line is care that is provided by the OPO team or the organ procurement organization team. And that's care that's really focused on maximizing the function of organs for transplant and maximizing the gift that the donor is giving to other people. It does also include grief measures for the family. So you'll see that that orange line goes right through that box. And that's because that really is a shared responsibility of both the clinical care team for the patient as well as the organ procurement organization team. So that's the brain death donation pathway that some patients might take. There's a second pathway to deceased donor donation called DCD, or donation after circulatory death donation. In the case of DCD, again, a patient has a devastating injury, does not necessarily need to be a neurologic injury. These injuries can occur for other reasons, but it has to be an injury for which the family has decided to withdraw life-sustaining treatment. So they've decided that whatever this injury is so severe that recovery is unlikely, or that recovery would not be consistent with the patient's values. And so the family has decided to withdraw life-sustaining treatment. At the point where they've decided to withdraw, that family is again approached, or the donor registry can be checked to look for authorization for donation. If there is not consent and no first person authorization, life-sustaining treatment is withdrawn in the ICU per standard practice with comfort medication, support for the family, so on and so forth. Legal death occurs after the life-sustaining treatment is withdrawn, and grief measures are provided for the family. So that's probably the most traditional route to patients dying in the ICU that most folks are pretty familiar with. On the other hand, if the patient and or family have given consent for donation, we'll again follow that lower line where life-sustaining treatment is withdrawn in the operating room or in a perioperative space. And the reason for that is that in donation after circulatory death, it's very important to remove the organs from the donating patient as soon as possible. That maximizes the health of those organs as they're transplanted into a new recipient, and makes it most likely that that organ will survive in that new person and be able to do its job. Because of that, the time it would take to move a patient from an ICU or other palliative care setting to the operating room, prep them for surgery, and then procure the organs would likely make those organs not viable for transplant. So instead, while the patient is still alive, they are actually moved down to the operating room, accompanied by family, friends, whomever else might be involved in their end-of-life process. They are actually frequently prepped for surgery in the operating room, so their belly or chest would be sterilized with betadine, as you would for any other operative procedure, prior to stopping that life-sustaining treatment. Life-sustaining treatment would again be stopped in the operating room. The comfort medications that you would provide for this patient would still be offered, so you'd still give sedatives or pain control as you'd need in order to make sure that the patient is comfortable. Two things can then happen. Legal death can occur relatively quickly. I'm not going to say a particular time because the time will vary depending on the organs being recovered and the experience and preferences of the recovering surgical team. But within a relatively brief period of time, on the order of 1 to 2 hours, death can occur. If that does occur, the organs are immediately recovered while the patient is in the operating room, and then grief measures would be provided for the family. If death does not occur in that time frame, the patient is moved back to an ICU, and we continue with end-of-life care as per our typical routines, and the patient would presumably die once they're back in the ICU at some point. That can be minutes, hours, days, weeks, or even longer after that. As many of you know, it can be very difficult to predict how long a patient would survive after the withdrawal of life-sustaining treatment, and that is the reason that I show both of those pathways. I think one of the critical things to notice in this particular slide is that that orange line distinguishing care provided by the ICU team and the OPO team is a little bit fuzzy when you talk about where life-sustaining treatment is withdrawn in the operating room. Because some of the things like preparation for surgery or also potentially administration of medications like heparin for anticoagulation may occur while the patient is still alive, but may be primarily driven by the desire to procure organs after that patient has died. The care is still legally under the responsibility of the ICU team until the time that death occurs, but there are some interventions that are not focused on the patient's well-being so much as on maximizing the gift that that patient is giving to the recipients of those organs. So that line can get a little bit fuzzy, and we'll see evidence of that as I go through the rest of this talk. As you can see through that, this is a complicated process, and there are multiple organizations that are involved in donation and transplantation. This just gives examples of how it might look in a particular system. So UNOS is a national network of organizations that are involved in the organ recovery and distribution process in the United States. It's a private entity that has a sole contract with the federal government as the only provider of that service. So they are kind of an umbrella organization on top of organ procurement organizations and transplant hospitals and systems throughout the country. They help with identifying prioritization for where a deceased donor's organs might go, criteria for donation, ensuring that matching is done in an equitable and fair way. Kind of at the more local level, there are local organ procurement organizations that are assigned geographic areas where they exclusively provide services to patients and hospitals where donors are. So they will approach families in order to make requests for organ or tissue donation. They will provide education in their communities about what organ and tissue donation looks like and ways to become involved or to become authorized as a first person yourself if that's something that you would choose to do. And they provide education to hospitals and their staff about how the organ donation process occurs. There's a hospital where the donation occurs. I just put a picture of my hospital here, but many hospitals can have donation occur where that patient would die, as we've talked about. And then there's frequently a second hospital where the recipient is, where the transplant actually occurs. And that, again, can be in many centers throughout the country, not necessarily the same hospital where the donation. next thing I want to talk about are some federal law changes that have affected the way organ procurement organizations are governed and the way that they are monitored by the federal government. I think that the biggest change to talk about is a change to 42 CFR 486, which is a regulation that is from the Center for Medicare and Medicaid Services that governs how organ procurement organizations are required to be run. It took effect in August of last year, so August of 2020. And had changes to the things you see on this slide. I'll go through each of these in a little bit more detail. So the first thing that changed that's significant in my mind, at least, are some of the measures of success for organ procurement organizations. So under the old system, there were two numbers that were calculated. The first was what was called a donation rate ratio, and it was simply the number of donors over the number of people who were declared brain dead under the age of 75, which was thought of as kind of the pool of likely donors or potential donors within an organ procurement organization's coverage area. So that would be just straight the number of people who are donating over the number of people declared brain dead. The organ yield ratio would be the number of organs that were transplanted over the number of donors. So were you, when you had a person who said yes to donation, were you actually getting the most number of organs possible out of that particular person and placed into a potential recipient? So were you doing a good job of matching and finding people who would be willing to accept those organs? Under the new regulations, those have changed a little bit. So the donation rate ratio is not just authorization for donation, but actually successfully transplanting at least one organ. So the top part of that ratio is now people who actually have successful transplantation, which certainly was designed to increase the incentive for organ procurement organizations to successfully transplant rather than just get people to say yes. And the denominator in that has become much broader. So it's actually the number of inpatient deaths of people under 75 years old who have a cause of death that's amenable to transplant, which is basically a long list of ICD-10 codes that the CMS has declared would be consistent with the ability to transplant. So things that aren't cancer or other things that would preclude transplant. Similarly, the transplantation rate ratio has changed significantly as well. So the top is still the number of transplanted organs, but instead of looking at that per number of donors, it's actually per number of deaths. Because the concern was that the former measure encouraged people to have fewer donors, but to transplant all of the organs from those donors. This new method is intended instead to allow benefit to OPOs who have a donor who might only be able to donate one organ, and they would actually still have that number of transplant organs number go up, while the number of inpatient deaths would remain constant for that OPO. So it would create a benefit to them transplanting even one organ from a patient who might only have one organ that was eligible to be transplanted because of matching or because of the health of the organs. So these measures have changed, and I do think they've increased the pressure on OPOs to successfully transplant organs and to maximize the number of donors, even donors who might have relatively limited ability to affect other people. Second change. So the frequency of review of organ procurement organizations has increased from every 4 years to every year, and that those reviews will actually be independent from recertification. So in the past, every 4 years, there would be a review of how well an OPO was doing as part of its recertification process. Those have now been changed so that there will actually be a report provided to OPOs on a yearly basis, and then in addition, they will still need to be recertified every 4 years. This is perhaps the biggest change, at least in my mind, for how the law has changed. That's in benchmarking of OPOs. So using those two numbers I gave you before, the ratios that I gave you before, OPOs are now benchmarked against each other. And what happens is that OPOs are placed into tiers based on their percentile rate ratios from, again, those two numbers I'd mentioned before. There is a little bit of overlap here that I'll get into in a second, but in broad strokes, the top 25% of OPOs, when you kind of stack them up one after another, are automatically recertified, are able to keep the exclusive contract for their coverage area without any competition, and are able to continue their practice as usual. They're still given, information about ways that you might be able to improve quality or improve performance, but there's not a risk of them losing their coverage area or losing their certification. The second tier, the next 25%, so from the 50th percentile to the 75th percentile, do have to compete for recertification. So potentially a different OPO could come in and compete with that with the original OPO for that service area, but they are eligible to compete and be recertified if they're in that second tier category. In the third tier, tier 3, which is the bottom 50%, the OPOs are decertified and they are not eligible to compete for recertification, which effectively means that OPO is no longer able to get the contract for the area they'd previously covered, which for many OPOs that cover only one designated geographic region would mean that they would go out of business. This is complicated a little bit because CMS is planning to use some statistical techniques that mean that these will not be exactly 25%. And if you read their techniques, their hope is that everybody will kind of excel to the top and have very similar ratios. And if that occurs, the statistics do theoretically allow for everybody to be in tier 1. However, I think that's pretty unlikely to actually happen. And I think that there will likely be some OPOs that end up in tier 3 and are decertified. So this obviously increases pressure on OPOs. One of the big criticisms of this particular approach is that it does not take into account any of the baseline demographics or transplant authorization rates in the areas that OPOs cover. So many OPOs cover regions where there's historically less trust in the healthcare system and they have historically lower transplant rates, and there's no benefit given to those OPOs. We're fortunate here in Colorado that we actually have fairly high authorization rates compared to many places around the country, and I would argue relatively high trust in the healthcare system. And so our OPO benefits from that, where an OPO in a different region might actually suffer from that. And that's not something that's really within the control of the OPO and may increase some equity concerns on a national level. Related to the benchmarking is transparency. This is not really intended to be read, but this is just an example of what CMS is putting up on their website at this point. So this is public information, and what they put up is every organ procurement organization across the countries, the rates that I just mentioned, so that transplant rate and the donation rate that I'd mentioned before, and where they fit in. So if you're highlighted in yellow or orange, it means that you're in either tier 2 or tier 3. And so are at risk for being in those lower tiers and having to do more to be able to keep your certification area. You look at the far right here, they'll actually tell you which tier you would be in based on data from 2019 or 2020. And this is published on an annual rolling basis so that OPOs and the public are able to see how they are doing relative to other organizations. To use that data from 2019 and 2020, if that had been the year that this had taken effect, in 2019, you can see almost half would actually have been tier 1, again, using those statistics that CMS is using. So 46% would have been automatically recertified. An additional quarter of OPOs would have been eligible to compete. And about 28% would have lost their certification and had difficulty maintaining their business or nonprofit organization status. In 2020, it actually divided out relatively evenly. So tier 1, tier 2, and tier 3 were all about the same size. But I think what I can see from this is that that tier 3 group is likely to be in kind of that 20 to 40% range, which really does create an existential threat to OPOs. And I think creates pressure on OPOs and to have to make decisions to maximize both donation authorization rates as well as transplant. I'll just throw out, we don't know what the changes will be, but there are likely additional changes coming to the United States transplant system. There has been a lot of discussion about breaking up UNOS or putting UNOS's contract up for rebid. And it's not entirely clear how that will play out, but there will certainly be more to come on how the transplant process will be changing in the United States. On this third part of the talk, what I'd really like to do is go through some controversies in organ procurement. I'm going to focus on 2 in particular. And the reason I went through the federal law changes first is I think as I go through this, you may be able to see some places where there may be incentives for OPOs to take these technologies and use them more quickly than they might without those incentives that the federal law provides. And we'll see how that works as we go through them. The first technique I'm going to talk about is called normothermic regional perfusion. So what you see on the left is the typical way that organs might be transplanted or might be perfused, excuse me, after they've been removed from a person. They're placed into a machine. That machine is able to provide oxygenation, glucose, all the other things that an organ needs in order to remain healthy as it's being transported from the donor to wherever the recipient is located. On the right side, what you see is an ECMO circuit, which is the type of circuit that's used in normothermic regional perfusion, where an organ is actually reperfused within a person's body before later being transitioned to one of the portable machines that move to the recipient. There are two types of normothermic regional perfusion that you'll see illustrated here. On the left, you see thoracoabdominal, or TA, normothermic regional perfusion. You'll sometimes see that abbreviated TA-NRP. What TA-NRP involves doing is, again, placing that patient on ECMO. You can see that the red and the blue lines from that ECMO circuit go into the chest. So they typically would go into the aorta and the vena cava. So the large blood vessels that are in the chest. The blood is taken out of the patient's body, run through this machine. It gets oxygen added to it, carbon dioxide removed from it, is restored to the patient, and is then able to provide that oxygenated blood to the heart, to the lungs, and to the abdominal organs. And that would allow them to be reperfused. They are then, in a more controlled, slow fashion, able to be removed from the person, placed on a device to perfuse them as they're being transitioned to the recipient. You'll notice also in that slide that there are 3 hemostats that clamp off the blood vessels that go towards the upper circulation. The reason for that is to attempt to stop any blood flow to the brain. The patient, as you may recall, has just been declared dead, so their heart has just stopped. And it is not clear that every neuron in the brain is dead, including every neuron that might be able to sense pain. And so the idea behind clamping those is to prevent the possibility of perfusing any part of the brain that might be able to have consciousness or sense pain. And so if you occlude those vessels, no blood is going. Presumably, those neurons will not wake up and be able to feel anything, and thus will ensure that the patient is kept comfortable. On the right side, you see abdominal normothermic regional perfusion. In abdominal, or ANRP, what you'll actually see is that those red and blue lines go into the groin, so they come in from below. They typically don't go as high, although they can. The goal behind abdominal normothermic regional perfusion is to just perfuse abdominal organs and not worry so much about perfusing the heart and the lungs. The clips here are actually shown high. There have also been some case reports of those clips being done actually at the level of the diaphragm, so that there is no circulation that goes above the diaphragm. All the circulation remains in the abdominal region. But again, the reason for those clamps is to avoid any potential circulation to the brain of oxygen blood. Why would we do this? Why would this be a good idea? There are some studies out there suggest that normothermic regional perfusion may increase the success of grafts in recipients. So on the left here, the key number is at the bottom of that green box where it says graft loss of 12% with NRP versus 24% with a normal technique. So at least in this study, they were able to show that NRP actually resulted in more successful transplantation of livers into recipients than did traditional techniques. And so that enhances the likelihood that the gift that the donor is giving will be able to use successfully. There's similar data for hearts and lungs that's been published. And so that's the big benefit that people see, is that you may be able to increase the success of transplants in the recipient. I will say I don't think that this data is super robust at this point. This is a relatively new technique. There is data that supports it. There's also some more equivocal data. So I think that research is certainly ongoing in this field, and it's important. What about the ethics of this? So I think there's a couple things that come to mind as you think through this. The first is when we go back to what the definition of death is for our dead donor rule for deceased organ donation, we say that an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. NRP applies to patients who are undergoing DCD. Applies to people who have that first definition of death, irreversible cessation of circulatory and respiratory function. There's been a lot of discussion in the transplant world and in the ethics world about whether NRP actually restores circulatory function and therefore demonstrates that the cessation of circulatory and respiratory function is not in fact irreversible, because it has been reversed. There are others who say that circulatory function is only restored to a limited part of the body. It's not whole body circulation, which is what the law intended, and therefore it doesn't actually reverse the irreversible cessation of circulatory and respiratory functions. It instead provides local perfusion only to those organs. I think both of those arguments have very credible thought behind them, and I don't think there's been a clear consensus in the community over which of those arguments ought to be held superior to the other. But that's kind of an ongoing debate, I think. And this has implications for not just the OPO and the patient, but it also has implications for the team that is declaring death. So when a physician signs a death certificate, they are signing that they believe that irreversible cessation of circulatory and respiratory function occurs. So if an individual physician believes that restoring circulation with NRP makes it not irreversible, then they can't declare death, which means that you can't proceed down the organ donation pathway and you end up in a vicious cycle. So I think that there's a lot of room for ongoing discussion between critical care, perioperative teams and organ procurement organizations about how best to blend what the law says and what practices might be acceptable for the declaring physicians. The second ethical consideration I think to think about is consent and transparency. This hasn't been well studied yet, but anecdotally across the country, there have been discussions about how much information should be disclosed to the family of a person who is donating. The NRP will be used as part of the recovery process. And again, there are two sides to this argument. On the one side are people who believe that the family should be given all information that might affect their decision about whether to donate or whether to use particular techniques in their donation process. And that would require telling those folks about NRP and how that works and what might occur with it. On the other hand, there are people who say, well, the family has made a decision that they want to donate their loved one's organs, or that their loved one wanted to donate their own organs, and they want to maximize that gift. That's their goal. And this is a way to potentially do that. And it's not really relevant to the family how we do that, as long as we're respectful to the person who has died, and as long as they are able to maximize the gift of that person. And so providing them those details may be unsettling or make them uncomfortable, make them think about things that they would rather not think about. And so it is better to not tell them and instead have a more general discussion about how organs are recovered without going into specific techniques. Similarly, you wouldn't go into a specific technique about how a surgeon would make an incision to be able to, recover a heart or a liver for a future transplant, because that's not something that most families want to hear about in detail. And this would fall into that category under that argument. Again, I don't think there's clear consensus. I do think there's maybe a little bit more push in the ethics world that consent and transparency for NRP specifically is important, but I don't think that that's established as a universal imperative yet. And then the third question I asked here is about transient sensation. There are some studies out of Europe that suggest that there aren't changes to things like EEG during NRP type procedures, in particular with the occlusion of the blood vessels that supply the brain. There's even some data that suggests there's not changes when you don't occlude those vessels. But I don't think that we know enough to be sure that there can't be transient sensation. I don't think that there's a zero risk. I agree that the risk is very, very low, but I don't think that there's no risk. And again, when we're talking about consent and transparency, I think considering that risk is important. One of the concerns that has been brought up is that many patients have what's called collateral circulation, which means that typically you have kind of 3 large blood vessels that are supplying circulation to your brain. But many people have additional smaller blood vessels that do provide some degree of blood flow to the brain, and those are not typically occluded in NRP. And is it possible that one of those small blood vessels could result in a sensation of pain or even a sensation of consciousness in a person who is undergoing NRP for organ procurement? I think it's very low likelihood, but I don't think it's impossible. And I think it's something that at least needs to be thought about in the context of NRP. The second issue I just wanted to touch on are honor walks. Many of you may have seen these. Honor walks are done for deceased organ donors, both brain dead donors as well as donation after circulatory death donors. where hospital staff members line the halls of a institution as the patient is being wheeled to the operating room for the recovery of their organs. Typically, people will be standing silently and respectfully as the person is wheeled by. And it's designed to be a show of gratitude for the gift and respect for the decision that the person made to donate their organs. And there are benefits to that. So there's a lot of media coverage about this. So everything from the New York Times to CNN to YouTube and TikTok have had versions of this story or similar stories explaining how honor walks might occur in hospitals and allowing publicizing what happens during these honor walks. Some OPOs, not our OPO locally, but OPOs in other areas actually provide resources for how to do honor walks on their website. And their thought process is that by doing honor walks, you both honor the person who has chosen to donate, you normalize the process of donation, and you raise awareness about donation in the community when people see stories in local media or on social media about a person who chose to donate and had an honor walk provided. And like I said, these occur not just in traditional media, but also in social media outlets. I do think honor walks have not really been considered from an ethical perspective in any great detail. And I think there's a few places where there might be concerns. I think there are equity and justice concerns in a couple of different ways. The first is that, as I mentioned, there are some communities that are less likely to choose to donate, often because of mistrust in the medical system. Often those are communities that are already disadvantaged in various ways. So we know that donation rates are less in communities of color, and that those communities are also less likely to trust the medical system. And the thought is there's likely an association between those two features. So if that person chose not to, or that family or person chose not to donate because of their mistrust of the medical system, they don't get this same honor walk. They don't get this same respect for their death. And in some ways, they may view their death as less their loved one's death is viewed as less meaningful, which can only exacerbate some of those pre-existing disparities in the healthcare system. So I think that's a concern. I also think there are concerns with people who are not eligible to donate within an ICU. So we have had situations in intensive care units where there's a patient who is having an honor walk who is eligible to donate. And at a similar time, there is a second patient in that same ICU who is dying, who is not eligible to donate for reasons that are not under their control. So they are dying of cancer, and because of that, they were deemed ineligible for donation. Again, I think it's very easy to see a perception from those family members that the person who chose to donate their organs' death was more meaningful or more valuable than the person who was not able to donate. And that perception can be very harmful to trust in the medical system. It can be harmful to the grieving process for those families. I think that's something to consider as well. The second piece to think about, I think, is the dignity of the donor. So literally all of these people are being transferred to the operating room on their deathbed. And in a situation where I'm not sure every person would be comfortable being, frankly, paraded through a hospital, even when the goal is to show them respect. So family members do make a decision to do this. They're not required to do it. So there is a consent process through the family member, but the person who is actually in the bed did not consent to this for the most part. They were not involved in discussions about whether this was a way they wanted to be seen. And so I think there are concerns that we could be violating the dignity of some of these donors. The third concern I have relates to privacy and confidentiality. Again, many of these walks occur in private areas, but some do occur in public areas. So there are some hospitals that do honor walks that include public spaces of the hospital where members of the public may be able to see what is happening or take pictures or all the other things that can happen in public areas of hospitals. And then these are also frequently publicized, again, with the family's permission, but I still think there are some significant privacy and confidentiality concerns about how the person who is in the bed is being viewed by others outside of their immediate circle. And then fourth, I think there are conflicts of interest here in terms of benefits to others. So that goes on several levels. At the broadest level, I think that promoting honor walks helps to, or could be seen as an organ procurement organization or a hospital focusing on the good of their transplant program rather than the good of the individual patient. And I think that's a significant risk whether that's the intention of the OPO or the hospital or not. I think it could be easily viewed that way. I also think there is a potential conflict of interest with the family member of the person who is deceased, because they are often included in the honor walk. They get that same respect and appreciation that the person who is donating receives. And so there is a incentive, I think, for some family members to agree to it, even if it is not necessarily what the person who is dying or has died would want. And I think both of those conflicts of interest are difficult to mitigate. So I will say at our hospital here on the Anschutz campus at Children's, we do not currently do honor walks, as we are still working through many of these concerns. There may well be ways to address these and to make honor walks more equitable and respectful of the people who are donating, but I don't think we've figured out the right approach yet. And until we do, we've decided to pause and work through those issues first. In summary, I'll tie this all up with a bow, since I answered almost no questions today and just hopefully provided a lot of thought-provoking questions. Organ procurement technology is definitely rapidly advancing, whether that's through NRP or whether it's through ex vivo outside of the body circulation techniques that may be less ethically problematic. I do think there's a lot of pressure on OPOs to increase the frequency of organ donation. I will say, as a person who works frequently with our OPO here in Colorado, I think our OPO has actually done a really good job of managing that pressure and not exerting it on hospitals. I don't think that has always been the case for all OPOs across the country. And I worry that as some of those federal law changes continue and OPOs do start to get decertified, that those pressures will only ratchet up, and it'll make it difficult for OPOs to balance their the good of the patient who's died, the good of the hospitals that they're working with, and also their own interest in ensuring that they're able to continue to exist as an OPO. I do think there are some new processes and approaches to donation that do have ethical concerns. I don't think they've been sufficiently explored, so I think there's a lot of work still to do in these areas. And because of that, I would urge a slowdown of adoption of both NRP and honor walks to allow more in-depth analysis, more people to have conversation and dialogue about how these techniques can be ethically justified, or how some of the ethical concerns can best be mitigated. And with that, I'm hoping that I asked enough questions and I'll provoke some discussion from the group.
Thank you very, very much, Brian. Really appreciate it. First question is, actually, do you foresee a change in U.S. policy or practice to presume donation unless patients or families opt out?
So I don't think that's likely in the United States. I think that in the US, there's not enough global trust and not enough kind of communitarian idealism to make an opt-out program politically acceptable. I think there's a strong ethical justification actually for doing that. For having an opt-out program. I think people in general expect to be able to be placed on a transplant list if they need an organ, and that the reciprocal obligation is that you would be willing to donate an organ if you're on the other end. So I think ethically there's a strong argument for having an opt-out system, or even a no potential to opt-out system. But I don't think that's a politically palatable solution in the United States right now.
Okay, thank you. So there is in the chat a question, does the transplant community have an ethics opinion about the harvesting of organs in the 2 patients at Lagone, New York City, in patients who did not provide informed consent and had carotids closed off, declared dead, and organs harvested?
So I am not familiar with that specific case, and I kind of hesitate to comment on it without being familiar with that case. So I'm going to defer that question.
Okay. Can you address the question, and this is sort of a consent question, if a patient has communicated that they would want to donate their organs, but the family is unanimously objecting to it, how does that work?
Yeah, so that's been a interesting question, especially in light of this new law. So historically, I think most OPOs have tried to respect first-person consent as kind of the highest priority, because that is the expressed wishes of the person who has died. Having said that, if an entire family was standing at the bedside saying, no, no, don't do that, I think most OPOs would say, we're not going to push that issue. Like, we're not going to force this family to go through something that would be very traumatic for them. I do think that in the the changes in law and the CMS regulations, that there may be a little bit more push to continue to honor first person authorization. That may very well be the ethically right thing to do anyway. But I think that that creates an extra incentive to kind of honor that first person authorization where it exists. That's also come up in the context of donation after circulatory death. So historically, first person authorization, so the deceased person's own, yes, I want to donate, has applied to donation after brain death or neurologic death, and hasn't really been applied to donation after circulatory death. There has been a move from some OPOs to actually apply that first person authorization to donation after circulatory death, which, at least in my mind, further blurs the line between what is the responsibility of the treating team in an ICU and what's the responsibility of that OPO. So for most patients who undergo donation after circulatory death, the ICU team has always viewed themselves as in charge of how that withdrawal of life-sustaining treatment occurs, where it occurs, and when it occurs. And if first person authorization is applied to those, that would actually remove some of that control from the ICU team and move it to the OPO so that organs can be recovered under that first person authorization. So that's definitely been a new point of, I think, disagreement between some ICU teams and OPOs.
Great, thank you. Going back to the slides you had on the changes in regulations, there's a question about what prompted these changes in the regulations and review processes.
Yeah, so the regulations were changed as part of an executive order that President Trump signed that was designed to decrease the number of patients in dialysis by increasing the availability of kidneys for transplant. So really the goal of this was the perception that the organ donation and distribution process in the United States was not working well, that people were languishing on lists waiting for transplant, were dying while waiting for transplants, which is absolutely true. That is a big problem in this country, and that this was a way to provide more incentive to streamline processes, share best practices among organ procurement organizations that are able to successfully transplant organs, and to reward those entities and hopefully allow them to expand, cover more geographic area, use their best practices for more people, and in the end to more efficiently distribute organs that are available for transplant, to decrease waiting, decrease people dying on the waiting list, and decrease people needing dialysis or other organ therapies.
Great, thank you. There are a number of comments. There's been a good bit of conversation about cerebral occlusion and questions about if there are studies that really assess the efficacy of the clamping and how we know whether it meets its goal of preventing conscious experience. Can you speak more to the clamping and the occlusion?
Yeah, so I do think that most studies that have been done are pretty consistent that clamping is effective in stopping circulation to the brain. I think there are two caveats to that. One is that it is very hard to know what the status of individual neurons are as a person is dying. So whether or what the status of a particular neural circuit might be as a person is dying. And so I retain concerns about how much transient sensation or consciousness might be possible for a person who has DCD. I actually think that concern would probably occur even if there were like pretty good evidence that the ligation was successful. But I'm not sure there's clear evidence. I'm not even sure what that evidence could really look like because it is so hard to monitor exactly what a person is perceiving as they're dying, because they're not going to be able to tell you. And so I think that that's a difficult question to answer. And at some point, we'll probably just have to make a decision that we're sure enough, even if we're not completely sure. And that's probably okay. But I think we need to be transparent about how we're making that decision and what we're thinking about as we go through it.
Mm-hmm. Okay, thanks. There's another comment. I share your ethical concerns about honor walks. I've encountered a lot of resistance to voicing these concerns in medical spaces. How do you talk to healthcare professionals and administrators about this?
Yeah, so I think this is a place where stories can be very effective. So if you have had a situation, as we have in our hospitals, where a family member was upset or saddened by seeing an honor walk for another patient, while their own relative did not receive one for whatever reason, I think that that story can be very powerful in illustrating how families might perceive what is clearly well intended. Like, I think everybody who is participating in honor walks in hospitals, I don't mean to ascribe malintention to them or that they believe that one death is more valuable than another, but I think trying to encourage those health professionals to put themselves in the shoes of a family that is already grieving the loss of a relative or friend, that is not familiar with how deaths in hospitals typically occur, and that probably doesn't know the ICU team that well, since most patients are not in ICUs for that long. How that might be perceived by a family, it may be very different from how it was intended by the people who are participating in that honor walk. So I think stories can be helpful, and encouraging people to put themselves in the shoes of that other family can be really helpful techniques. I think that approach is more effective than focusing on some of the bigger picture justice, conflict of interest issues. Certainly people who are welcome to talk about those as well, but I think the stories are often more effective talking to clinicians.
Okay. What are your thoughts about the AAN adopting a permanence standard in violation of the UDDA for DNC?
That is a great question that I do not have a great answer to. Um, I think that permanence is the right standard. I don't think irreversible is the right standard, and I don't think we actually achieve irreversible really ever. I really wish that there were a way to change the law without all the concerns that the Uniform Law Commission that was considering revising the UDDA had about reopening that law and all the potential mischief that could go on if that law was reopened for public debate. So there are little changes to the law like that that I think would be really helpful. So I guess what I would say is, from an ethical standpoint, I don't think permanence is a problem. I am not an attorney, and I will leave it to the attorneys to decide how much they want to push on the difference between irreversible and permanent in the legal sense.
Okay, it seems we violate the dead donor rule in at least 3 ways. 1, it's unclear NRP donors are really dead. 2, pre-mortem interventions like heparin. 3, brain dead donors are not legally dead because guidelines do not require, quote, cessation of all functions of the entire brain, since they ignore hypothalamic functions.
So I would agree with 1 and 3. I think premortem interventions, I can make a little bit better argument for, because they are not directly causing the death of the person, and they aren't removing a vital organ. They're actually preparing a patient for removal of vital organ. And so I can construct an argument that those are more similar to things like administering heparin premortem is more similar to lab testing than it is to the other two. But I do agree, I think it's unclear that NRP donors are really dead. And I agree that brain dead donors do not meet the all functions, including hypothalamic function. So from an ethical perspective, I'm actually okay getting rid of the dead donor rule. I think that you can create an ethical system that does not have a dead donor rule, but does have donation by consent for people who are dying anyway, even if the precise moment of death occurs slightly before or slightly after the vital organ is removed. So I am okay with that from an ethical perspective, but I think legally, obviously, that's a huge problem. And as a public trust in the organ donation system, I think that's also a non-starter and is unlikely to change in my lifetime.
Mm-hmm. What discussion points do you think are necessary in discussions with donor families in regard to DCD procurement techniques being used? And how can we as a community make these discussions effective when discussing a highly complex topic?
Yeah, I really appreciate that question, because it is really complex. And I do think there are families who don't want to know. And I think that's okay. Like, I don't think we should force families to know if they don't want to know. So I think this is a really great opportunity to actually go to families and ask them, There are some families who want to know like everything we are going to do. And I think that if that's the case, that we should be as like detailed as we can be in explaining, the same as you would for any other surgical procedure where a patient said, I really want to know all the details of, what could go wrong or what vessels you might ligate, all those kinds of questions that a person might ask about their own surgery. I think we should be able to answer for families. A lot of families, I think, will say, I just want the highlights, or I just I don't care. Like, that's not my concern. My concern is do the most good possible. And I think that's fine. If that's what they say, then it is fine to just speak in generalities and not go into detail. But I think we should at least be providing the opportunity for families to ask about what techniques would be used and to ask for more details about what would happen when their loved one is in the operating room.
Mhm. Okay. There are a number of comments back and forth, both in this state and in Arizona. This is back to OPOs not proceeding with a patient's decision, the first person decision, when the family objects, and a number saying that OPOs do push, and hospitals have not supported the decision, and they move forward with the donation. So I think it's variable.
Yeah, no, I think it is variable, and I do think that there is an argument that the OPO is obligated to respect first person authorization over a family's objection. So I don't mean to say that OPOs are bad for trying to do that, because first person authorization is important. In lots of other areas of end of life care, we argue strongly from an ethics perspective that if the person themselves said they do or don't want particular care, that should take precedence over their family members' wishes. And there's not a particular reason that should be different for this. So actually, I think there is a pretty strong argument for following that first person authorization. I just think that blurring that line over who is in control for some of these DCD patients can get us into trouble.
I think there is, as people are pointing out, a real difference between what is legally legally okay to do and what is maybe ethically tending to grief and so forth that is so important, and balancing that. And different OPOs, I think, work differently with that.
Yeah, I think most OPOs do a lot to try to support the grief of family members. I know ours here does quite a bit in terms of offering support to family members. And they actually offer that even if the patient was not as able to donate organs. So that I think is something that would go a long way towards addressing some of the justice and equity concerns, is to work to provide some of those supports to people, whether they choose to donate or not, or whether the donation or whether the organs are able to be successfully procured or not.
How would you respond to the argument that eliminating the dead donor rule objectifies the donor as merely an organ source rather than a person worthy of respect?
Yeah, so that's the big argument for keeping the dead donor rule, is that we're just using people as a means to an end as soon as we get rid of it, and that's a problem. I think what I would say is that the person is, I think that we would still need to construct that system in such a way that the decision to withdraw life-sustaining treatment and to that the understood, I don't know if intention is the right word, but the understood outcome of that decision would be that the person dies in the very near future, right? Like, so you would probably have to pick a time. I don't know if you pick hours, but some number of hours or a day or two into the future, that person is going to die, and they have made that decision ahead of time. And then you can have a discussion about organ donation. But saying that the precise moment matters, I think actually may infringe on the autonomy of some individuals. So we have had patients who have neuromuscular diseases, so ALS, for example. Cognitively, they would like to donate their organs, and there just is not a way to effectively get them into an operating room, and they are unlikely to die within the requisite time period for DCD. And so that person's autonomy actually is restricted by the fact of the dead donor rule. Even though they would prefer to be able to donate their organs, they are planning to stop their non-invasive ventilation or invasive ventilation anyway. The expectation is just that they would survive for 6 hours instead of 1 hour. And so they wouldn't be eligible to donate their organs. And that actually causes a lot of grief for some of those people. And I think that can actually be disrespectful to that individual as a person who has some autonomy over making a decision about how they die.
Yeah. One last question. There are a number of others. I apologize to people for not being able to get to all of the comments and questions. How is first person authorization at the DMV comparable to informed consent?
So it is not. And I don't think that really anybody argues that it is comparable to informed consent. I do think that it offers insight into what the deceased person was thinking or what they valued or what they believed. In the same way that advanced directives are often, or MDPOAs are often not like truly informed consent. Like often people who have signed MDPOAs or other forms of advanced directives haven't gone into a great deal of detail about what exactly the specifics of treatment might be as you would for an informed consent process, but it still does provide information about what that person was thinking, what they valued, and what they wanted to happen to them, even if it's not true informed consent the way we would do for a typical medical procedure.
Right. Thank you very, very much. And thank you. There are a number of links to articles and comments, been very good discussion in the chat as well as with you. So I really appreciate your time, Dr. Jackson, and know that this has been most valuable to all of us. So thanks. Again, we will meet again for Ethics Grand Rounds on conscientious objection with Dr. Matt Winia on January the 11th. In the meantime, happy holidays to everyone, and we'll see you in a month. Thanks again.
Thanks for the great discussion.
Bye-bye.